Chris, thank you very much. Very pleased to be with everybody, old friends and new. And as Chris knows, I'm just delighted that there's so many journalists interested in vaccine-related issues. Very, very important. I've kind of got two quick messages today. The first is that it's flu season in anticipation, but it's flu vaccination season that is starting right now, and that's terribly important. Each year, we want to promote influenza vaccination to the US populace. The recommendations from the CDC couldn't be simpler. If you're older than 6 months of age, you should get vaccinated against flu each and every year. I will leave it to you to ask me lots of questions about that. I'll just make the point very quickly that this year it's more important than ever. And that's because we anticipate a twindemic. We have COVID, we're going to get flu. These two infections look an awful lot alike, and flu frequently strains the healthcare system all by itself. So what we can do to alleviate the strain on the healthcare system, protect ourselves at the same time, prevent ourselves from becoming dreaded spreaders, is to get vaccinated. So that much about flu. I'm happy to talk about that as much as you like. My other topic is related to what we hope will be one or more effective COVID vaccines. I think there's a large misapprehension out there. Namely, this vaccine has been so enthusiastically anticipated that I think the general public really hasn't thought very much about it. One of the things that's kind of in the mind of the general public, at least as I speak to some of my friends, is that effective equates with 100% effectiveness. You get the vaccine and you get a suit of armor, you're protected. You don't have to worry anymore. That is incorrect. First of all, there are few of us who, if the vaccines are shown to be effective, think that the vaccine will be 100% effective. We have some vaccines that approach that. Tetanus vaccine, measles vaccine, but we have other vaccines, including, I just mentioned it, influenza vaccine, which offers partial protection. Let's just say the COVID vaccine is 70% effective. That means for every 10 people vaccinated with the COVID vaccine, 3 will remain just as susceptible as they were before they were vaccinated, and we don't know who they are. This means, and I'll give you some other reasons to reinforce this, we'll have to continue our mask wearing, social distancing, et cetera, even after we start vaccinating. Number 2, it's a 2-dose vaccine, at least the 2 leading candidates are, separated by a month. So that will just take time to effect. You know, we're trying to vaccinate basically the entire US population. We'll have to do that twice in order for it to be effective, and we'll have to keep track of that. That will take time before that protection from 2 doses is actually factored in. Number 3, we won't have enough vaccine for everybody on the front end, so the vaccine will be delivered over time. That will once again stretch out the period of time where we will be delivering this vaccine to the US population. And lastly, there are a lot of people who've said in surveys already they're very skeptical about vaccines. They're going to hold back and watch what happens rather than line up and roll up their sleeves. So that will leave many people unvaccinated, particularly early on, and maybe entirely. You know, you put all those things together, and it's clear we're still going to have to wear our masks. We'll still have to social distance. And the vaccine is potentially, assuming it's effective and safe, or vaccines, fundamental to our approach to trying to control COVID in our country. but it's not a magic wand. It won't make the virus disappear. We'll have to keep on social distancing. My prediction, we're at the end of September now in 2020. If we come together at the end of September 2021, we'll still be wearing masks. That's sobering. That will not be a message that is well received. It is not well communicated. We've done this experiment once in the sense that we all locked down. The population was not instructed that when we opened up, we had to open up carefully with our masks and social distancing. So a lot of people were careless or carefree at the very least. And now we have COVID out there. Unless our population is well prepared, that we're going to have to continue our behavioral interventions, masking, social distancing, even while we're vaccinating, and for months while we're vaccinating, we still will not have an effective, coherent national policy to control COVID. Take your questions. Thank you very much.
Okay. So why don't you all get your hands up? One question I have for you is an article recently in the British Medical Journal about whether many people have pre-existing immunity. There's a general feeling, there has been the general feeling that there is no pre-existing immunity to SARS-CoV-2. But I guess there have been some studies that suggest there might be. I mean, do you have any thoughts on that?
Well, I'm much influenced by one of my colleagues here at Vanderbilt, who is one of the international experts on coronaviruses. He's studied them his entire life, and he has told us if there is any crossover immunity, it's trivial. So I think there isn't much. There certainly doesn't appear to be very much, because this virus is very contagious and it continues to spread very readily.
Okay. All right, so let's go to some questions from our fellows. When I call on you, give Dr. Schaffner your name and your publication so he knows who he's talking to, and tell us if you are a 2019 or a 2020 fellow. Let's go to Anjali.
Thank you, Chris. Dr. Schaffner, Anjali Kimlani with Yahoo Finance here. I'm a 2020 fellow. And thank you for your very emphatic reminder that a vaccine is not 100% the be-all, end-all. And I think that's something that we may or may not struggle to tell every day. At least it's something that I personally do. So just to go off of that, I think that's something that generally we see businesses, some of these larger companies, looking to as the starting point to reopen offices and the like. If masks are still going to be required and social distancing still required, what would you say about that sort of mentality right now, and how do we change that, or what is required for these companies to look at going forward?
Thank you very much. I think slowly and carefully. The companies that I'm aware of, including my own institution here, have been doing that slowly and carefully and trying to assess, for example, everyone that comes into the institution. We get a temperature check. We have to tell people whether we have any symptoms. We remain spaced out. Many of our personnel, in fact, still the majority of my whole research team is working from home, and we continue to do that. Putting in barriers, checking air handling to make sure we get an optimal number of air exchanges, and doing a whole host of things such as that to try to make workplaces absolutely as safe as possible. And it's the sort of thing that you encounter going into, at least in my neck of the woods, grocery stores. Everybody's functioning behind plexiglass barriers at the present time. So there are many things that we can do to reduce our risk. One of my quips is I don't like to use four-letter words such as safe, because that implies complete safety. What we're doing is trying to reduce our risk. And by doing a whole series of things, we can create fairly reasonable barriers between us and the virus. Each of them individually, temperature monitoring, it has limitations. So it's like a whole series of slices of Swiss cheese. Each one provides a barrier, but each one has gaps. But then you put in another barrier, it has its own gaps, and then a third barrier and a fourth. But if you put a whole series of slices of Swiss cheese together, you've got pretty reasonable barriers between you and the virus. But you have to do them all. And you have to do them all consistently. You can't do them all at work and then go to the bars in the evening, take off your masks and hobnob with your friends. That zaps the whole operation.
The Swiss cheese analogy, did you come up with that one on your own?
Yeah.
I
Love
like
it.
that.
Thank you.
All right. So
My mother was Swiss.
okay. I just have one other question. We got plenty of fellow questions, but the National Foundation for Infectious Diseases, which you're a board member of or have been a board member of, and for the fellows out there, Dr. Marita, who talked with us in 2020 as a board member of, and
Yes.
Marla Dalton, and Kathy Newsel from Maryland, who the 2019 fellows met. They have some recent information about the the vaccination rates for other vaccines and what's happening this year, and they've seen a dramatic decline in vaccination rates, since March. Nobody's going to the doctor. Can you talk a little bit about how big of a problem that is, and is it possible to recover by people getting those vaccinations, although they'll be 6 months or 12 months late doing so?
Sure. So thanks, Chris. Yes, it's quite clear that during the lockdown period, people didn't go to their healthcare providers. Moms and dads didn't take in young children. Adults did not go to their providers. And we did a lot of telemedicine. But most of us haven't figured out yet how to immunize through the computer. You actually have to show up in person. And it's clear that routine child immunization rates, those are the ones that have been tracked the most, really took a substantial, worrisome dip during that lockdown period. The CDC's MMWR just a few weeks ago sent out a report showing that we're starting to recover now. And so we're coming back, bringing our children, bringing ourselves back to the healthcare provider. It's a caution of a lot of older adults who are being very careful about COVID, about going to the provider to get their flu shots, because they're hesitant about going into any healthcare provider's office, fearing that they may be exposed to COVID. And so a lot of providers now are having special flu clinics, flu vaccination clinics, so people can get in and out very, very quickly. And of course, you can go to a pharmacy. Flu vaccination is also going to be impeded. A lot of us are still working from home, and so we can't get our flu vaccine in an occupational setting, right? So we're going to have to be individually initiative in order to get those vaccines. So that's all a problem. And Chris, I'll take advantage of your mentioning the NFID. I was originally going to save this to last, but the NFID annually provides a news conference. Used to be at the National Press Club. We've done it for over 20 years, which ushers in the influenza vaccination season. This year it'll be virtual. It will be on October 1st. You're all invited. We always have a keynote speaker, and this year we'll have the Babe Ruth of the era. Tony Fauci will be our keynote speaker, so I know you'll all want to tune in.
Yes, and we'll find the link for that and send everybody information on that. So we'll get in our follow-up emails. We'll include that. So let's go to Andrew Dunn.
Dr. Schaffner, this is Andrew Dunn from Business Insider, a 2020 fellow of the program. There's been a lot of talk about emergency use authorization. I was wondering, yourself as an expert in this field, what do you want to see as far as sample size and follow-up time for effectiveness and safety data? Obviously, the FDA is going to eventually put out their own guidance on what they want to see. What would you want to see as an expert in this to actually ensure this is safe and effective, as far as how many people the data represents and the length of follow-up?
Yeah, so thanks, Andrew. I don't have absolute numerical guidelines myself. I note that the FDA would like to increase the follow-up period, for example, before they issue an emergency use authorization. I think that that's a good thing. There are two things that we look for in these trials: efficacy and safety. And we sometimes forget the safety because we're also interested in how well the vaccine works. But the safety database is as important. After all, this is a new virus in a new host, humans. You know, the textbook is blank pages. We're writing about what we know about this virus as we go along. We're learning more and more about its immunology. And here we are creating vaccines with technologies for which there are no precedents, at least in licensed vaccines. As one of my friends said, gee, what could go wrong? So the safety database is very, very important, and even more important in these circumstances. And when surveys are done among people in the general population, the people who evidence some skepticism, and that ranges from a third to a half of the population, it's the safety issue that they're concerned about. And this is reflected in the professional discussions that I've had. So my short answer is, the more, the better. I think most of us would like, really optimally, from a scientific point of view, to wait until these trials are completed rather than get EUAs, emergency use authorizations, during the time when you can take a quick look, a peek at the results, and then halfway through the trial, decide that the vaccine is good enough to get an EUA. Who knows what will happen? These are difficult circumstances, and there's a reasonable discussion about this because 1,000 people are dying every day. So maybe a smaller database will suffice. We want to make sure that whatever decision is made, it goes through the FDA's advisory committee of external experts that then would agree. Dr. Offit, among others, is a member of that committee. And if they give it the thumbs up, that will be very important. And the more information we get about the trial and the results that come from professional sources rather than political sources, the more comfortable everyone will be.
Okay, so let's go to Umair Irfan.
Hi, Dr. Schaffner. My name is Umair Irfan. I'm a staff writer at Vox, and I'm a 2020 fellow for the National Press Foundation. I appreciated your mention of the influenza vaccine and the fact that we give it to everybody over the age of 6 months, but I'm kind of curious how the logistics of deploying that compare to what we would expect with a COVID-19 vaccine. Basically, how do we get it to the 300 million people of this country? How does that compare to what we've already done? Or is this a completely new and unique animal, and how should we prepare for that?
Well, the flu vaccine is very traditional, Romer. It is distributed, I would say 90%, maybe even more than that, through the private sector. Pediatricians, family doctors, internists, occupational settings, pharmacies play an important role, senior citizen centers, and all of those kinds of circumstances. This is not a vaccine that is delivered principally through public health departments, although they have some for people who have absolutely no resources. One of the good things about flu vaccine is that virtually every kind of medical insurance will cover the vaccine and an administration fee. Almost every kind of medical insurance. Some insurances have deductibles, and if you don't reach the deductible and there isn't a little clause in there that says, well, influenza vaccine doesn't count, you get that free anyway. So sometimes you have to pay out of pocket. But that's the mechanism whereby influenza vaccine is distributed. What we're trying to do is get every person to seek the vaccine and every provider to be assertive in insisting, really, not just recommending, insisting that their patients receive it, especially this year. The manufacturers have made more vaccine than ever before, and they're ready to make even more if we can use it. And the CDC has purchased more vaccine, distributing it to the public health departments to be sure that they have enough vaccine to give it to people who don't have their own wherewithal to get the vaccine. So it should be available theoretically to everybody who wants it in the United States. Now, this is in contrast to the way, and this is still a bit murky, the way the COVID vaccines will be distributed. And as far as we know, I think the major distribution mechanism will be as traditionally with that we've used, for example, for the 2009 H1N1 swine flu vaccine through the CDC to health departments and then allocations. There are some complications here. The two leading vaccines have distinctive shipping and handling constraints regarding the cold chain. And so at least one of these vaccines probably will not, in fact, for sure, will not be able to be distributed to private doctors' offices and local clinics and such, but will only be distributed in major institutions where they can keep the vaccine at a deep freeze and there's sufficient throughput in their clinics so that every time they open a vial, they can use it because they have enough people in line, because you can't thaw it out and then keep it for very long. It has to be used in a very expeditious fashion. We don't know all the details of how the COVID vaccines will be distributed and made available yet. So hold on with that. Everybody's waiting a little bit until all of the states are all working on distribution plans. We don't know the details of all those vaccines yet, including whether some of them may work better in some populations than others. And that will substantially influence how you target the vaccine and promote it. Thank you.
Okay, so next we'll go to Kira Peikoff.
Hi, thank you so much. I'm Kira from Leaps Mag. It's a digital magazine about scientific innovation. And my question relates to older adults. So older adults obviously have a much greater risk of getting sick and dying from the virus. And yet the older adults that I've spoken with are hesitant to take a vaccine that has limited follow-up data, especially in the coming years. So my question for you is, how would you advise older adults who are thinking through whether to get a vaccine? When should they feel comfortable taking a vaccine in which we don't know what the long-term effects are or how they affect potentially people whose immune systems are a little weaker?
Yeah, so Kira, this is a very, very important question. And some of those people, as I said before, may be just inherently more careful about going to a healthcare provider about getting their vaccine also. We sure want them to get flu vaccine. And as you undoubtedly know, we have two vaccines that are explicitly licensed for people age 65 and older because they work better in those populations. And we would like those older folks to get one of those vaccines particularly. Now, apropos of the COVID vaccine, we start with a more general problem, namely that with any new vaccine that's introduced, we obviously don't have really long-term data. We have generally pretty short-term data, and it's stay tuned. We'll let you know how well this vaccine works over time. But some of the overtones of your question have to do also with safety. After you get the vaccine, for how long have we been able to observe the participants to see if something might show up a month, 2 months, 3 months later that wasn't anticipated at the actual time of vaccination? And we already know that these, at least the two leading vaccines, are kind of ouchy vaccines. They make arms sore, you get some swelling, you feel kind of crummy, have a headache for a day or two, and a small proportion of them have fever for a day or so. So we already know that that's an issue. and we'll have to work hard to get them in for the second dose. If the first one hurt, am I going to come back for the second one? There is that issue. I think we need as large a safety database as possible. And then we have to describe what we know as clearly, honestly, transparently, and rigorously as possible. We have to do it with as little hype as possible. And that information, from my point of view, ought to come from professional sources, and people who are interested in the vaccine ought to be able to get that information through all the efforts that you all are going to do, and also from their provider. They ought to be able to sit down, think about this, read about it, and ask questions and get sufficiently reassured so that they can help make their decisions. I can't think of any other way to do that. We will have some data. In the minds of some, it won't be enough, but we'll just have to communicate what it is that we know. And of course, as a friend of mine always likes to say, okay, you've got all that information, compared to what? And what compared to what is, ooh, there's COVID out there. So make that balanced judgment, right? Thank you.
Okay, so next up, Sam Whitehead.
Hey, Dr. Schaffner, thanks for doing this, and thanks to NPF for doing this. I'm with WABE. We're the NPR affiliate down here in Atlanta, Georgia, and I was a fellow last year, so it's great to be able to tune in. Dr. Schaffner, I want to just kind of make sure I'm clear on something you said earlier about vaccine effectiveness. You said if we want to consider a vaccine as 70% effective, the way to think about that is 7 of 10 people have protection and 3 don't. I'm also wondering if the way to frame that, or if it's fair to say that those 10 people would also have 70% protection. I think if I'm trying to think about whether or not I'm going to get a vaccine, I would much rather think I'm going to be 70% infected rather than I'm one of potentially 3 very unlucky people who has no protection. And I'm thinking that the way we frame that to our audience is probably going to matter a little bit too. So could you clarify that for me?
Well, Sam, we have to be careful with language. If we tell a group of people that they're 70% protected, what that usually means to us is that the effectiveness of the vaccine in preventing the serious outcomes, and that's the major endpoint, is that we will protect 7 out of 10 people. There may be some additional data. I don't think it will come out of these trials, but they may develop later, that similar to the flu vaccine, even if you get the vaccine and then subsequently become infected and become ill, you'll have a less severe infection. That's also an important asset of the vaccine. And that goes to your point that even the people who don't get protected completely may have partial protection. I don't think we'll know that at the end of the trials. We won't have followed enough people long enough, right? And so we'll just have to see what the in-use effectiveness of the vaccine is, and that will be monitored in populations. Lots of people will be doing studies, often led by the CDC, looking at that. Incidentally, the CDC is also ginning up its whole existing network of post-marketing safety surveillance for vaccines, and that will also be operative. So we'll be constantly monitoring in-use safety issues as well as effectiveness issues. And so we'll be modifying, enhancing the data as we get more information. I hope that addresses, if not completely answers your question.
Well, sure. And if a quick follow-up, if I could, I mean, how long will it take in those kind of post-market follow-ups to figure this out? I mean, I maybe this is a question without a clear answer. I'm just curious.
Yeah, I think it is without a clear answer. It will receive a lot of attention, I can assure you. My guesstimate is it will take 6 to 8 months to get some early information about that. So much depends on how effective the vaccine is and how quickly the vaccine will be accepted by the general population, right?
Okay. So next we have Lisa Krieger, who's from the San Jose Mercury News. But Lisa, are you still based out in Alaska?
I am back in California. Thank
Okay.
you. But yeah, thank you for asking. Thank you so much for addressing the transparency and EUA issue, Doctor. And I've got a related sort of regulatory or political question for you. Because as vaccines work their way towards federal authorization or approval, what assurances do we have of the transparency of that process and of the data? How public is that? And are there opportunities in this process for the administration to influence it? And I guess we're talking about the NIH's Data Safety and Monitoring Board and then the FDA Advisory Committee that you referenced. Are there firewalls to protect them from influence?
As to the latter, we live in unorthodox times. Had you asked me this question 8 months ago, I would have said there assuredly are firewalls. I'm not so sure about those firewalls at all, because two of the major governmental institutions that are so active at this time, the Food and Drug Administration and the CDC, I mean, there's widely reported information that both of them have had political influence and indeed, I would say, interference. So they're both trying to restore their integrity on the fly at the present time. But there's a great deal of skepticism in the general population and also among medical professionals, and beyond profound disappointment in all of this. So that's the answer to your second question. We would look very strongly to the external advisory group, VRPAC, of the Food and Drug Administration. They are a well-known, independent, and very rigorous group. And if they give the thumbs up, I think that will reassure the medical community. But thumbs up is not enough. You know, there's that old saying, in God we trust, all others must provide data. And I think everyone, certainly the medical community, will want to see the data which form the basis of the recommendations. And I think that that is going to be more important than ever, that sort of transparency. And if an emergency use authorization comes whilst the trial is still underway, you know, we're allowed to peek at the data periodically according to the protocols. So if it's an early emergency use authorization, those data will be scrutinized not only by the External Advisory Committee, but also by a lot of us out in the field. And there may be some controversy that results, but the key is presenting the data at the time the recommendation is made.
So it sounds as though there will be an opportunity then for experts like yourself to actually see the data.
It is the hope and the expectation, yes. And I think the Food and Drug Administration has done its best over the past weeks to try to restore some of that confidence that they hope the medical community will have with the FDA process. But I mean, they've said they're going to present the data.
Great. Thank you. And Chris, indulge me, just another really quick question.
Sure, quick one.
If the FDA Advisory Committee does give it a thumbs up or a thumbs down, does the FDA Commissioner typically follow that recommendation?
Typically.
Lindy Washburn.
Hi, thank you for taking my question. I work for the Gannett newspapers in New Jersey and was a fellow last year. I wondered if you could go into some detail about what would constitute herd immunity. And if a vaccine is only 70% effective and only a portion of the population gets it because of skepticism or logistics, how helpful will that be, really?
So, Lindsay, good question. So just so that we're all on the same page, herd immunity or community protection results when any kind of infectious agent, a virus, for example, uh, infects a sufficiently large proportion of the population so that the communicability, the contagiousness of the virus in question is substantially reduced. This depends an awful lot on the degree of contagiousness of the virus. Measles, which we think is the most contagious virus we know, requires for this kind of community protection where the virus can't find another person that's susceptible. That proportion of the population is very high. It's like 90+%. For chickenpox, it's down around 70% or thereabouts. The COVID virus is a very contagious virus. Exactly where that level of community protection is, there are various estimates that range from 60 to 80+%. Personally, I'm up on the higher end because I think this is a highly contagious virus and it can spread from people who have no symptoms. So you can't avoid the person who is actually shedding the virus. That's why we all have to wear masks, right? So the vaccine, whatever its degree of effectiveness is, the more people that get it, the more people will have a degree of personal protection, and the more will contribute within families, any kind of local group. But if you're looking for protection for large communities, and communities that range from rural small towns to New York City, well, obviously, the higher the proportion of people who accept the vaccine, the better. There'll always be some benefit, but waiting for herd immunity will need very, very high levels of protection in our community. Now, the higher you get, the more the curves will be dampened. So you won't get big peaks of infection, but the virus can kind of smolder along in the community, attacking this person here, that person there, smoldering along. That would be what we call control. Nobody expects that we will eliminate this virus from our population. It's going to smolder along. But if we can push it down really far, we will have achieved a public health triumph. Fair?
All right, next
Thank you.
question. Next question to David Lim.
Hi, this is David Lim. I'm a 2020 fellow. I work for Politico. I wanted to ask about the current circumstances we found ourselves in, specifically when it comes to how the public perceives a future vaccine in the context of how some of the reporters on this call probably are covering the current events that are going on, remarks by the country's leaders. How does an expert like yourself kind of see the balance of preserving perception of the promise of a vaccine with the legitimate concern public health experts are raising about some of the remarks that we're hearing right now?
David, you've given me a very tough question. I think what the experts can do is be as professional and non-political as possible. Call the balls and strikes straight on, talk about what the vaccine can do, what it can't, what the side effects to the vaccine are, and then provide recommendations and reassurance. And we hope that that conforms with the national recommendations, so we don't get into a push-pull, and just try to keep doing that as consistently as possible. We know we have a lot of vaccine hesitancy out there, and already, even though we don't have COVID vaccines licensed, we know we have that core group of anti-vaccine people already disparaging the vaccine and the process that is leading to its development. Unless we do this right, I think that core group of anti-vaccine people will rise up and say, you see, we were right all along. There are conspiracies between the government and these large industries, and people are just trying to make money off you, etc., etc. So I think we can just do the best we can and as clearly as possible, in plain language, provide the best scientific-based advice along with recommendations and reassurance. All of those are necessary in a sustained fashion. If you want to refine your question, I'll try to address it, but that's the best I can do, I think.
Yeah, no, thank you for trying to answer the question. It's been something I've personally been thinking about a lot lately.
Okay, next question, Sony Salzman.
Hey, Dr. Schaffner. Sony Salzman from ABC. I'm a 2020 fellow. I have two questions for you. One is kind of on topic with vaccine and another maybe a little bit off topic. But the first question, I'd love if you could talk a bit about pediatric trials. It seems to me that there's a growing awareness that we're going to have a rollout of vaccine, but it's not going to be available for children. And at ABC, some of my colleagues have been talking about what that might mean for schools, not only this year, but are we going to be living like this for those folks, you know, who have kids, school-age kids next year as well. So I'd love for you to maybe talk about what the timeline might look like for a pediatric vaccine for COVID-19. And then second, I'd love to just hear your thoughts about the kind of CDC whiplash. I think we touched base about this with airborne transmission, the guidance that went up and then came down, and now there's been nothing. You know, do you think that the CDC should talk about airborne transmission on its website?
Let me deal with the first question first. You can't do everything at once. And with a new virus in a new population and new vaccine technologies, it was thought, particularly since the biggest hit this virus does on the population is in adults, particularly older adults, that's where we would study this vaccine first. We wouldn't start injecting 5-year-olds before we knew what this vaccine did in adults. And there's just so much physically and fiscally that companies can do along with taxpayer money to do trials. So the trials in adults are running. As soon as they come to a conclusion, I mean, people are already planning pediatric trials, and as soon as these adult trials come to conclusion, pediatric trials will be undertaken. Probably fairly quickly, I would anticipate, but this is a guesstimate, the middle of next year. So we'll see that. Apropos of the benefits of the adult implementation to children, remember, the most important thing we can do to protect school children at the present time is to reduce community transmission of the virus. And so if the adults in that community, if we had an effective vaccine, if the adults in that community would accept the vaccine, we can immunize the teachers, the entire staff, all the parents, everybody in that community. That will immediately reduce the risk to children enormously. And then when we have the information to get around to it, to vaccinate the children, we can do that, maybe I shouldn't say this, mop-up operation. But I really think it's important to get community transmission down and vaccinate all the adults associated with schools. That will be a big benefit. Apropos of your second question, very briefly, as some of you know, I call myself the president of the CDC fan club, and everything that's happened to the CDC regarding political interference has really broken my heart. Short answer to your question is, we do need more clear guidance regarding the extent of airborne transmission. It's still debated in public health circles about how important that is. That it happens is undoubted, but is it really that important? Is it really that frequent? You know, airborne transmission is thought to be not very important in influenza, and we see how widely influenza spread. That's all close in transmission. Is it the same with COVID, or is COVID more likely to be transmitted by airborne? We don't know that yet, but regardless, given the state of the art, how much emphasis should we be putting? How much attention, how much money should we be putting into revising our air handling systems in all the buildings in this country? Not trivial questions, and the science supporting that is not as strong as we would like. So, but people are out there wanting the guidance, and we should have some more, I think, guidance from the CDC, even if it's winds up being dealer's choice. Here are the data. We can't make firm recommendations. If you want to enhance your air conditioning systems, go right ahead. You know, even if it's that much, I think it would be appreciated.
All right, Dr. Schaffner, a heads up on time. Are you able to stick with us? Given the number of questions we have, I think we'll be going till 12:10 your time. Is that good for you? Okay.
Absolutely.
So we can get through everybody's questions. Up next is Sarah Klein.
Hi there, Sarah Klein. I'm from Livestrong.com and I'm a 2020 fellow. So we've seen that this coronavirus is mutating, albeit it sounds like slowly. Is there any indication yet that we'll need to adapt a COVID vaccine or vaccines yearly like we do with flu, or is it just too early to tell?
Good, you're playing chess. Thank you. Thinking several moves in advance. First of all, a bit of reassurance. This virus has been, everything considered, remarkably stable from a genetic point of view. Of course, there are minor mutations or kind of around the edges, and the molecular biologists can distinguish strains of the virus, those that likely came from China from those that likely came from Europe. That's equivalent to whatever sport coat you put on that day. It doesn't affect your essential nature, your inner part, the critical part. The most critical part, of course, is that part of the virus. If you think of the virus as a sphere with all those points sticking out of it, that's why it was called coronavirus, because it reminded the initial investigators of a crown. And those are the spike proteins. Those spike proteins get up next to the cell back in my throat, and it's like a key getting into a lock. That goes in, and that allows the virus to enter the cell and start multiplying within the cell. That's the key protein against which the vaccines are created. They want the antibodies to cover up those spike proteins so the spike protein can't get into the cell. There's been some mutation in that spike protein that some people think make it easier to get into the cell. Therefore, the individual sheds more virus because more virus is produced, making the virus more transmissible. And there's a strain of the virus for which that appears to be the case. But the essential nature of the spike protein is still stable. So the vaccines we're producing should produce that antibody to lock it in. So at the moment, we don't think there's going to be so much mutation that like the flu vaccine, we'll have to change the vaccine. However, what we don't know is how long the protection acquired persists. How durable is it? Is it possible, even if the virus does not change, that we might have to be revaccinated at some frequent interval? Could be. Stay tuned. Don't know the answer to that yet.
Okay, next question to Leslie McClurg.
There we go. Okay. Yeah, Leslie McClurg. I work for the San Francisco NPR affiliate, and I was a 2020 fellow. And Dr. Schaffner, we talked super early on. I was one of those reporters that wrote one of those articles, and we didn't know very much. Like, the flu is a way bigger fear for the country than the coronavirus. And
yeah, I thought that too.
Yeah, you told me that.
Wrong.
I'm curious how, looking back over the last year, how would you just sort of in a 30,000 foot statement, how do you compare COVID to the flu? How do we re-educate our population about those two viruses?
Flu has the capacity to do things such as COVID. COVID has been, stunning. It's surprised all of us how transmissible it is and how within a couple of months it spread to every continent on the globe except Antarctica. That is amazing. Even flu has never been transmitted that rapidly. Of course, part of that has to do with the mobility of populations today. Every year that goes by, except recently, more people are on airplanes traveling to more distant places around the world, and they can carry these germs with them, right? And so that clearly accelerated the transmission of this highly infectious virus. Compared to the two, I think basically COVID is more transmissible than the flu, and it tends to make more severe disease than the flu. That said, let's not underestimate influenza. Influenza comes every year. Familiarity breeds, if not contempt, at least a certain nonchalance about flu. We generally underestimate the seriousness of flu. So we've got two bad guys out there, and distinguishing between the two, one is badder than the other bad guy, yeah, maybe that's of interest, but they're both bad guys.
One quick follow-up. I have heard some speculate that because the flu didn't, I guess, appear as nasty in the Southern Hemisphere this year, that it won't come back as bad to us this year, especially with all our protective measures, that this fear around this big flu the fall may not unfold. What do you think of that?
Well, our friends in Australia and New Zealand who had a very low flu season this summer, their winter, say they attribute this to two things. One is they used more influenza vaccine than they ever have before in those countries. They used a lot more. And number two, they were really pretty compliant, not perfect, but really pretty compliant with social distancing and mask wearing. And they think the two of them conspired to do that. We're half measures at both. We don't vaccinate nearly as many people as we would like against influenza, and not nearly as many people are wearing masks and doing social distancing as I would like in this country. So we need to gin up on both of those in order to have an aspiration or an expectation of having a low flu season.
Thank you.
Next up, Matthew Hudson.
Hi, Matt Hudson. I'm a freelance science reporter, 2020 fellow. This might be a little bit outside of your area, but there's some evidence that antibodies don't last very long after an infection, and by extension, they might not last very long after vaccination. But B cells and T cells might remain primed. Are you hopeful that after vaccination, there would be that effect of the B cells and T cells remaining primed for a long time? And is it difficult to test for that?
You can test for that, Matthew. Yeah, well, first of all, of course, I'm hopeful. But you can test for that, I think, through re-immunization or watching populations as they get re-exposed to the wild virus, right? And see how well protected people are and for how long. The issue with a respiratory virus is one that causes damage right on the respiratory epithelium, is that the body has to respond immediately. It's not like measles. Measles settles on the respiratory epithelium, multiplies, and then goes through the body, through the bloodstream. And that's where the vaccine works. It stops the measles virus when it circulates in the bloodstream. COVID does that also. And that's probably the mechanism that is going to be used to prevent severe disease. All right? Whether it can prevent the actual infection, that we don't know yet. We'll have to wait and see.
Next up, Melissa Healy.
Hi there, Dr. Schaffner. Melissa Healy from the LA Times. Thank you so much for doing this. I'm a 2020 fellow on this. Listen, I wonder if I could. One of the results of Operation Warp Speed and the great number of vaccine candidates that are making their way through the pipeline is that number one, there will be many. Number two, that they will have different designs and different mechanisms of action. Number three, that they will all differ probably somewhat in their effectiveness and possibly, as you point out, in the populations in which they'll be effective. Some will be two-shot vaccines, some will be one-shot vaccines. And if this is anything like everything else in COVID, the rollout of these vaccines will probably be incredibly shambolic. So one thing I wonder about is, do you worry at all about cross-reactivity? I mean, if a person basically gets...
say that again, cross-reaction?
Cross-reactivity of vaccines. In other words, if a person gets one shot of one vaccine, goes back to 3 weeks later or 4 weeks later to the
yes,
the clinic and gets a shot of brand Y, I mean, all bets are off about that person's protection, much less about the safety, et cetera, et cetera. I just wonder, I mean,
yeah, you're
also
well
the question of generally, do you foresee a lot of confusion, but is there also danger in that confusion?
So yeah, first of all, you were very optimistic about your anticipation that there would be many vaccines that are effective and will be introduced. I share that hope. And then you got a little cautious in saying that the introduction will be shambolic, and I'm afraid about that too. So I'll share your worry. Very clearly, you can't mix and match. So we shouldn't do that. That will not be recommended. As a consequence, we will have to have an enormously complex record-keeping system so we know exactly what I got and when I got it. So when I'm due for my second dose, they will know the interval, the provider will know the interval, decide whether it's appropriate, and give me a second dose of the vaccine I'm to receive. And just to build on you, I've already been asked the question, if I get vaccinated with the first vaccine, and then another one is licensed 4 months later, and some people think it's better, can I get that second vaccine? Then there will be no data to support that. And so providers are going to be very cautious about doing anything like that. And to think about this a little further, you know that despite we're all being cautious, people do move around, and they may not go back to the same provider, who may actually not even be in the same state when they're looking for their second dose. So this record-keeping system that we're going to have is going to have to be better than any immunization registry that we currently have. And we'll see whether it's able to do that at the time we need it. Ma'am?
I mean, thoughts about the likelihood that that's going to work as hoped?
Well, my crystal ball is cloudy about likelihood, but I do know that people in the state health departments and the CDC, and that's where the responsibility is, are working on that overtime. So we all have our hopes. Hang in there. This is something that's unprecedented. We haven't done this before. And whenever you do new things, there'll be bumps in the road. So hang in there with all of us.
All right, so we have 4 more questions. So we'll probably be at this another 10 or 12 minutes or so, but let's go to Susan Berger.
Hi there. I'm Susan Berger. I'm a freelance reporter. I write primarily for the Washington Post and for the Chicago Tribune. I'm based in Chicago. My question is this. I'm on the board of our synagogue, and they've done virtual everything for many, many months. And just in the last few weeks, and the high holidays are all virtual and everything, but in the last few weeks, they're allowing small events for life events, you know, for bar mitzvahs or weddings or whatever, even funerals, having small events of, they said 25 people, but they may even go up to 50 because the recommendations in Illinois said they can.
Mm-hmm.
My question is this, is that everyone says with the fall coming, things are gonna get worse. And the positivity rate, where in our county, I think is under 5 right now, but
right
in the counties around us, it's going up. And Governor Pritzker's warned that he will close things down again if that happens. So I'm wondering, isn't it best to err on the side of caution? I mean, just to have, they're taking temperature checks with these people and they're taking their names so that they can contact trace if someone gets sick. But I'm just wondering if it's something they shouldn't be doing. You know, that it's just, at this point, why not be more careful until we get things more under control?
It strikes me as profound as these events are culturally, socially, and religiously. I think we ought to exercise real caution, both as an organization, that is the synagogue, but also as individuals, people who are older, anyone who has a chronic underlying illness probably ought to attend those events virtually. I think we all need to be careful. Life is precious. These are things we can do to protect ourselves and our families. So we ought to be very cautious, careful, rather than carefree, going when we consider how essential our attendance is at these sorts of events. And I reiterate, no matter how important and central and spiritual they are, and that's important to us as human beings. But that virus has job one. In fact, it's job only, infect someone else. And they love congregation.
Right. I have one more question too, and I'll be quick. In this area where it's going to be cold soon, a lot of the restaurants in my area, some of them have even last winter had what they call little igloos or greenhouses on the sidewalk where people can sit and eat. In the area where I live, in a small town, Glencoe, Illinois, the village board just passed allowing these igloos to go ahead this winter. It seems to me logically that's just a really bad idea. Am I right?
Well, my thought is the same as it was before. Consider very seriously yourself and your own personal circumstances. What's your individual risk tolerance? I'm a public health guy. I'm with Benjamin Franklin. An ounce of prevention is worth a pound of cure. So my family is being very, very careful and still not doing very much outside of the house other than going to the grocery store. Yeah. I need a haircut. I'm getting it at home. Doesn't look so great, but I'm not even going to the barber.
All right. So just a couple more. Taryn Mento.
Hi, yeah, I'm Taryn Mento. I'm at the NPR and PBS affiliate in San Diego, and I'm a 2020 fellow. You did address my question a bit earlier, talking about distribution and how it's difficult for states to plan because there's so much that's still unknown. But, you know, in LA County, they just ordered its health department to begin developing a distribution plan. You know, sure. in San Diego, a hospital established a committee to assess the eventual vaccine. So, you know, my question is, because there is so much unknown, what valuable actions, steps, or conversations should be happening now at local health departments? Because I plan on calling up my local health department after this call and asking them what they are doing today.
Well, health departments, state health departments, local health departments, my hospital is doing what the hospitals in San Diego are doing. We just formed a committee to address this. Given the different characteristics of the vaccine, how might we deliver this vaccine? How might we select the appropriate healthcare workers who we think are going to be first in line? How do we sort that out within the institution? How do we parse that? Where could we do that physically? If some of these vaccines, and one of them does, require a deep freeze, where would we locate that deep freeze? Who are the people who will then be trained in how to actually handle these vaccines so they don't get degraded in their use before they're inoculated into a person? All of those kinds of details, I think, are being looked at by state, local health departments, as well as healthcare institutions. And the state health departments are also looking at vaccines that might be more readily distributed to the practicing community. So as was done with the 2009 H1N1 vaccine, you had to raise your hand. I can use 100 doses. How were they allocated? How were they transported? How then is the accountability such that, given the prioritization scheme, does, for example, the doctor in their own office know what the prioritization scheme is and can then report back to the health department and be accountable for the appropriate use of that vaccine? All of those details, and I'm sure 20 dozen more, is what health departments are being done. Health departments are functioning on. The CDC has issued a fairly elaborate document which provides a template for starters, so everybody doesn't have to reinvent the wheel. It's actually a really pretty good document.
Would it be concerning if there wasn't this kind of conversation or a committee or a group at a public health department taking place right now?
Oh, I think they've got to be starting, because as we know, there's been so much talk about the imminence of a vaccine being made available, right? So, I mean, we've got to make some of these concrete plans ready to be flexible when the specific characteristics of the available vaccine become available. So you got to think about some options as you're planning.
Okay, last question back to Lisa Krieger.
Yes, thank you. But I'm off mute. I'm just following up there. Does the state have the prerogative to decide which vaccines it'll be administering? Can the state look at the data and make its own independent decision? And I love your explanation as to what they're confronting now, and any other thoughts you might have as to, just to flip the tables, if you were a journalist, what questions would you be asking them about vaccine rollout and distribution?
Well, it's early days, and I'm so empathetic with the people who are doing the planning. I'm not so sure I want to give you tough questions to ask, but I mean, you could ask about the general outline of the planning process. That's for sure. And those folks will have to keep getting back to you as they develop more concrete expressions of the plan. As to your other question, I have never encountered that question before. Could there be more than one vaccine available at any time, not just at the beginning, but during the course of more clinical trials coming to fruition? And could the states then make a decision about which vaccines to accept? I think they might well be able to do that we would prefer to have vaccine A rather than vaccine B. There might be some consequences to that. They might not get quite as much vaccine. They might get their vaccine A allocation, but not their vaccine B. Details. But yeah, I would think states might have some options.
Interesting, thank you. California Department of Health is saying they want to see the data independently and and make their own decisions about moving forward, which is interesting if each state makes that calculus.
Oh, each state indeed has that sort of responsibility. Some may be more ready to independently evaluate the data than others. You got 50 states, and I always forget how many territories. So, you know, it's a republic that we're living in.
Thank you.
Okay, well, one final hand went up under the wire. Mary Haynes, quick question for you.
Sure. Thanks, Chris and Dr. Schaffner. I'm with the Las Vegas Review-Journal. And I was talking to the primary investigator here in Las Vegas for the Moderna trials yesterday, and he said nobody has gotten sick yet. And I wondered if if this has happened. He didn't know, you know, what the stats were across the country, but I wondered if you could speak to the necessity of people getting sick in these trials, and also if this might suggest this whole time frame is going to be longer.
Lovely. I was wondering if that would come up. So we're vaccinating a lot of people in the trial. Half, it's a 1-to-1 allocation. Half will get the placebo and half will get the vaccine. And the whole point of the trial on the effectiveness side is to measure whether the people in the vaccine have a lower rate of infection than the people who are taking the placebo, right? And then you can measure exactly what proportion of these infections were prevented. That's the whole deal. But in order to do that, you have to have infections. So let's think a little bit, you and I and everybody else. Who volunteers for these trials? Well, by and large, it's traditional over the years, more educated and very health-oriented people. We're reaching out to other populations to make sure that the representation is as diverse as we can get. But many of the traditional volunteers, my daughter-in-law, for example, who's a volunteer, highly educated, very careful. Well, if so many of these volunteers are already very careful, the rate of infections will remain low, and it will take longer to accrue sufficient infections occurring in the populations in order to make the assessment, right? So it is true that some of these trials may go on longer than anticipated because the volunteers are being very health conscious, staying at home, wearing their masks, social distancing, not going out to bars. So that's a possibility.